Good morning. Welcome, and thank you for joining us for our Northern Light Health Good Health is Good Business Zoom conference. COVID-19 is not limited to acute disease with symptoms, hospitalizations, and deaths. In the October 13th Journal of the American Medical Association, or JAMA, an analysis of 57 different studies reported as many as 55% of SARS-CoV-2 infected people are suffering from prolonged symptoms or chronic symptoms lasting greater than 6 months. This aspect of COVID-19 is called long haulers or long COVID. In some instances, this is a devastating alteration of people's lives. While we appreciate there is a high level of stress related to long haulers, the chronicity of the pandemic also takes its toll on all of us, day after day after day. Today, our topics will include the latest on COVID-19, booster rollout, COVID long haulers and treatment, and ongoing COVID-19 stress. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Beacon Health. I'll be your moderator for the next hour. Our panelists today are Dr. Sue Ann Hammond, Primary Care Lead Physician at Northern Light Primary Care in Windham. Angela Felicia, Director of Healthy Life Resources Program at Northern Light Acadia Hospital. Dr. Jim Jarvis, Director of Clinical Education at Northern Light Eastern Maine Medical Center and Physician Leader for Vaccinations and COVID-19 Incident Command at Northern Light Health. Before we get started, I will read out legal disclosure. The coronavirus pandemic is an ongoing, continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. Northern Light Health does not know the particulars of your situation, so the information presented today is general in nature and is based upon Northern Light Health's own experience, which may or may not apply in your specific situation and may be revised as we learn more about the coronavirus. Accordingly, following any guidance Northern Light Health presents today in no way guarantees that you, your employees, and/or your customers and clients will not contract or spread the coronavirus. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with a COVID-19 update. Dr. Jarvis?
Thank you, Dr. Gilkey. Please, next slide. So this is an infographic that Northern Light Health has been sharing for a little over a month now, I believe, and we've updated it recently to give some more in-depth data. So remember, this is always a snapshot in time, and particularly with ICU, but with all of our hospitalizations, things change pretty quickly in the COVID world. But what this graph highlights is just looking at the number of people who are hospitalized across our 10 hospital systems, how many of them are intensive care unit, and how many of those in the intensive care unit are on ventilators, and whether or not they're vaccinated or unvaccinated. And when you look at the graph, we can see that we've seen an increase in the number of vaccinated individuals who have been admitted to our hospitals and in fact are requiring intensive care. But I want to state that still the majority of individuals have not yet been vaccinated. But then we look down at the bottom at the kind of the spread of where we see who those individuals are. We see that those who are vaccinated tend to be older than younger, but those who are unvaccinated really spread across. Obviously, people who are over age 60 are still at greatest risk for severe illness from COVID-19. But it is a cautionary tale that if you're unvaccinated, it doesn't matter what your age is or your health conditions, this can be a severe disease. Next slide, please. When we look at overall testing, I think the thing that there's two things that stand out in this graphic for me. One is that we continue to do a high number of tests across Northern Light Health, and our percent of tests that are positive has remained pretty steady now for a really long time, almost about a month. we look at our 2-week positivity rate of 10.35%, remember that that is the total number of positive tests divided by the total number of tests run by Northern Light Health Lab. That is a very high number, and we've really been steady around that 10% mark, sometimes dipping down to 9%, sometimes going up as high as 12%, but it has been pretty steady, and that mirrors what we've seen in the state of Maine, that our case counts have been steady for quite some time now, at a rate much higher than we would like to see. In fact, if you remember in the beginning of the pandemic, we talked about a 2-week positivity rate greater than 1% indicates that there is a significant amount of spread of the disease in our communities. And right now, we continue to be 10 times that number that we were worried about way back in the beginning of the pandemic. When we look at the Mayo Clinic's predictive model for the next 2 weeks, they pretty much have us staying at this same rate, which means that we're probably still going to be dealing with outbreaks, hospitalizations, and unfortunately deaths for the coming weeks. Next slide, please. So I'll talk about vaccine updates, and I'll give you the most up-to-date information, which really actually has to do with information that came out yesterday. I'll first talk about the issue around booster doses versus a third dose for people in their primary series. When we talk about a third dose of a vaccine for Pfizer or Moderna, that's what individuals who had their primary series but who are severely immunocompromised because either they're being treated for cancer, they have had an organ transplant and are on immunosuppressive drugs, or they're on immunosuppressive drugs for some other reason. All of those individuals over the age of 18 qualify for getting a third dose of their primary series of either Pfizer or Moderna. That recommendation has not come out as far as Johnson & Johnson goes. A booster shot, however, is for those individuals who had received their primary series a while ago, and we think that in certain categories it's necessary for them to receive a new booster dose. Initially, we were talking about that only for Pfizer, but late yesterday, the FDA approved Moderna to be added to that list for people who are over the age of 65, people between the ages of 40 and 65 who have underlying medical conditions, people who are between 18 and 40 who have underlying medical conditions may consider getting the booster shot, and then anyone over the age of 18 who had received Pfizer or Moderna may consider getting the booster shot if they're at a high-risk occupation, such as a healthcare worker, a person who's a first responder, or a person who works in any other industry where they come in frequent contact with many different people from the community, such as people in food services or grocery workers. That recommendation remains for Pfizer. For Moderna, we expect that the CDC will match that same recommendation later today, in which case then we can actually begin those booster shots for people who had originally received the Moderna vaccine. For people who had received the Johnson & Johnson vaccine initially, yesterday the FDA's advisory committee recommended that anyone over the age of 18 who had initially received the Johnson & Johnson vaccine, whether immunocompromised or not, should receive a booster shot if they received their Johnson & Johnson vaccine just 2 months or more ago. Again, we will have to wait to have that information validated by the CDC and recommended by the CDC before we can start implementing that. But that's a significant difference for the Johnson & Johnson than the Pfizer or the Moderna vaccine. There's a lot of questions there about mixing and matching the vaccines. And yesterday, the FDA voted again to allow mixing and matching of vaccines, meaning that if you had initially received Johnson & Johnson, you could get Pfizer or Moderna as your booster dose, or subsequently, if you had received Pfizer or Moderna, you can get one of the other two as the booster dose. There'll probably be more specific information about that coming from the CDC's advisory committee later today. So what about people under the age of 12? And remember, when I talked about all of those things had to do with 18, so there's still that gap period of those people who are between 12 and 18 who had initially received vaccine, and right now there is no recommendation for booster shots for those. But children under the age of 12, we expect that early next week or the week after, we will hear from both the FDA and the CDC's advisory committees on vaccines about administering the Pfizer vaccine to children between the ages of 5 and 12. This will be a different vaccine in terms of dosage than the Pfizer vaccine we administered to adults earlier. It is the same messenger RNA, so it is the same method of the way that it works and works on the exact same portion of the coronavirus that we talked about with the other Pfizer vaccine. It is just a lower amount of the actual mRNA that will be part of the vaccine. And so there will not be allowed to be mix and matching of those. And so it may take a little bit longer for us to start administering that because it is a different product once that approval or authorization occurs. I will state that right now that the state of Maine is already pre-ordering that vaccine so that there will be supply on hand, and we'll start distributing that through school-based clinics, our primary care and pediatric offices, our retail pharmacies, and if the state decides we need to set up special clinics to reach people beyond those methods, we will do that as well. And I think that's all for my update. So I'll turn it back to you, Ed.
Well, thanks, Jim. Next up is Dr. Hammond, who will help us understand COVID-19 long haulers. Sue Ann?
Thank you, Dr. Gilkey. I am joining you today to talk about patients who have symptoms of COVID longer than expected. And we're hearing terms like long COVID, long hauler, post-COVID, and more recently, PASC, P-A-S-C. Post-acute sequelae of COVID is really the emerging term that's being used across all of the healthcare organizations. And that's the term I suspect you'll hear more going forward. The general definition is still a work in progress, but overall being defined as somebody who has symptoms from the initial onset of their COVID infection that are lasting more than 4 weeks. The why behind this, we certainly don't understand yet. There are a lot of theories moving around. Mostly the top 3 include concern that there's residual organ damage from the first infection of COVID that remains greater than 4 weeks. There's a theory that there's remaining virus in the system, that the body has a little bit lower level and that displays itself in other ways, or that a patient is having exaggerated immune response to the initial infection that's lasting longer than 4 months. Next slide, please. This slide shows a timeline of the COVID-19 infection with an exposure starting on the left on the gray side with weeks considered -1 to -2 when the exposure occurs before symptoms occur. And then right on the middle, you see the change to blue when symptoms develop or a positive PCR test occurs. That time frame from the blue is typically 1 to 4 weeks. At the end of 4 weeks, most patients, 90% of patients have complete resolution of their symptoms. But approximately 10% of patients who have COVID-19 have remaining symptoms lasting longer than 4 weeks. Those symptoms have a wide range of distribution throughout the body, anywhere from general fatigue, muscle weakness, shortness of breath, continued cough, changes in sleep, changes in memory, trouble concentrating, palpitations or feeling of skipped heartbeat, as well as changes in skin, hair, etc. Next slide, please. Diagnosing post-acute sequelae, or PASC, is really something that's done by a diagnosis of exclusion. Each patient is going to present differently, and the provider is really challenged to evaluate the patient depending on what symptoms they have in the usual manner. If a patient presents with continued shortness of breath, we need to evaluate the shortness of breath with x-rays, labs, any cardiac or appropriate testing, the same as we would before COVID, to be sure that there's no other cause. Once a thorough evaluation is complete, then you're left with the diagnosis of shortness of breath or what other symptom they present with, in addition to having being a status post-COVID patient or a post-acute sequelae patient. It's at that point that treatment really focuses on the symptoms. So treatment right now is very therapeutic, looking at physical therapy, pulmonary therapy, even cognitive and speech therapy to really address the symptoms the patient continues to have. There's a lot of research regarding medications, things like nasal steroid sprays, whether or not they help with long-term changes in taste and smell. But all of this is very, very early, as this is our first time dealing with the COVID virus. And so now we need to learn quickly how to manage this virus and the symptoms that we haven't been through before. So across the country, clinics like the Cleveland Clinic, Yale, Mass General, and Brigham are all working to collect the data, continue to do research so that we can have more to offer for our patients who continue to suffer from symptoms of COVID after 4 months. In December of 2020, Congress approved $1.15 billion in funding over 4 years to support research into the prolonged health consequences of SARS-CoV-19. In February, the NIH launched a new initiative to study long COVID. So there are multiple approaches coming from every healthcare organization to help support the research that we need to do across all aspects of healthcare to learn more so that we have more to offer our patients moving forward. Next slide, please. Mercy's been fortunate to stand up a PASC clinic, post-acute COVID clinic at one of our walk-in care clinics. And patients are able to call or go through their primary care provider to be seen here. When a patient gets here, they're filling out a very thorough and detailed questionnaire as to when their actual acute COVID infection was, what symptoms they had at the time, and what symptoms they continue to have. They're seen by a provider who's going to do an evaluation based on their past medical history as well as their symptoms, and then to determine what testing makes sense to evaluate those symptoms. And as I said earlier, once other causes have been ruled out, then treatment can be focused on therapies to help that patient manage and hopefully start to recover from the symptoms that they continue to have.
Well, thank you, Dr. Hammond. Next is Angela Felicia, who will speak about ongoing stress and strategies to reduce it. Angela?
Thank you, Dr. Gilkey, and always thanks, Dr. Hammond and Jarvis, for fantastic information. Unfortunately, we are still in a pandemic. So we are still talking about what really is being kind of called that other pandemic, mental health issues. So we thought it was helpful to talk about trauma today in the midst of this ongoing crisis event. There's just some definitions of trauma. One of the things that makes crisis events so difficult is that it can have multiple different stressors. There can be one event, a singular horrific event that can cause a trauma response, but it can also be multiple events over time that can elicit that crisis or trauma response. Next slide. Anytime we're talking about the body's trauma response, it's really important to talk about the brain. Unfortunately, our bodies, our brains really can't tell the difference between a modern stressor and a life-threatening event. Our brains respond exactly the same way. We start going into that fight, flight, or freeze response. And the crisis response or stressors really occur when our fight, flight, or freeze response happens over time and is in overdrive. Next slide. And I apologize for my dog. I am working from home. Thought it was valuable also to take a look at what a typical crisis cycle looks like. So a typical crisis cycle follows this curve. We have some sort of crisis event, things ramp up, it's difficult, there's that peak, and then voila, the crisis is over. I often use something that we here in New England are familiar with, a nor'easter, right? We know that that's coming, that's the event, we get ourselves ramped up to deal with it, to make sure that we've got enough gas in the generator, the plow's all gassed up, and then the storm is over, we get to de-escalate, recover, go back to normal. Unfortunately, a long chronic stressor like COVID is not following this normal curve. Next slide. So instead following that normal crisis curve, we really are just kind of going around and around in a circle, right? There was definitely a time, early summer-ish, right, where I think many, if not all of us, were thinking, aha, we've rounded the corner here. We're on that road to recovery, but not quite. So we had the Delta surge, increasing hospitalizations, increasing infections, increased community spread. The school year started. I think all of us are probably hoping for a, quote, normal school year. It's anything but. So we continue to have that sensation of fight, flight, or freeze, agitation, peak stress. At some point, when the crisis levels off, we'll go back, and I hope, anyway, we don't end up back in this cycle, but this has been the pattern over the past 19 months. Just when we think things are going back to normal, nope, not quite. Next slide. And you can really see the impact of this circular crisis cycle by the numbers, right? So these numbers are from a 2020 survey conducted. So, we're a year past that, but these are the best national numbers we have that really indicate 40% of US adults are experiencing depression, anxiety, and or an increase in some sort of substance use, alcohol being the predominant substance of choice. You can see too that those instances of anxiety and depression are really hitting those young adults harder than the older adults. This is particularly concerning for those of us in the workforce, whereas it's typically that younger adult, middle-aged adult who continues to be in the workforce. Next slide. Now, certainly, you might be thinking, gosh, I'm not experiencing these trauma symptoms. That can absolutely be true, right? No two people having that same exposure to an event will respond exactly the same way. Much of that has to do with our own individual life circumstances, what types of traumas or crises we've had in the past, cultural factors, the types of support we continue to have ongoing. All of those factors will determine whether one person having a traumatic event will experience trauma and prolonged trauma reactions, and the next person will not. So it's very, very individualized. There are, however, things that we can all do, particularly in the workforce. Next slide. So there are ways we can really think about fostering resiliency. So social support can be really helpful to all of us, even if it's in a virtual format, right? FaceTime, Skype, there's all kinds of ways to maintain that connection and do so safely. Same with our coworkers, our colleagues. Having that social support, that social connection is critically important. We want to be able to maintain that and foster it. And where possible, having that financial stability can be really helpful, making healthcare affordable, really focusing on that workplace safety. Many workplace wellness programs focus on physical. We encourage, too, that idea of psychological safety, promoting diversity, equity, and inclusion, encouraging workers to utilize your employee assistance programs are all really critical. And then, of course, COVID safety. This is still a pandemic, so we want to make sure that we're providing for all of our workers adequate PPE, timely testing, and a real plan to minimize risk. Next slide. And then I am the director for our Healthy Life Resources program, so I'm always happy to hear from employers in the area on ways that we might be able to help your individual workforce. Thanks so much.
Well, thanks, Angela. For this next segment, we will ask our panelists to join on video and to answer your questions. Just a reminder to place your questions in the Q&A box. The first question is for Dr. Jarvis. If vaccinated people get the virus and transmit it to other people, how do you see the pandemic coming to an end? Oh, here's a crystal ball question for you, Dr. Jarvis.
I have it right here for you, Ed.
I know, it should be patented.
So, really that is a major question that we have to have. We know that as more individuals get vaccinated and more individuals get infected around the same time that people get vaccinated, we will overall lower the rate of virus as we all start to get more and more protection. And that's really what the key is. We talked about in the past herd or community immunity, meaning that enough people have protection against a particular disease, in this case COVID-19, that it doesn't allow as much community transmission, and then we see things kind of peter out. And really, we see that anyway with just natural peaks and flow with the COVID-19 virus. However, the low points have been much higher of late than we had seen in the past, and that's very concerning. And a lot of that has to do with there's a lot of circulating virus out there. So until we get enough of our population who at one particular time are immune for that particular time, either through vaccination or infection, we will continue to have these cycles. We also know that immunity wanes, particularly from infection, but also from vaccination. And so that kind of has that ebb and flow to it. This is very similar to what we see with influenza, which is why right now we're recommending that people get their influenza shot for the 2021-2022 season, because it's really important that we're vaccinated not only against COVID-19, but influenza. So I do think we're in for seeing that coronavirus becomes more like the seasonal flu, but hopefully we won't see it be the current pandemic situation we're in right now.
So are you seeing, any information that suggests that we might have a late fall winter surge this year?
The biggest indicator of that is really coming from the United Kingdom right now. So they are beginning to see a surge. We're also hearing reports that Russia is having a significant outbreak as well across its entire country. I would compare us more to the UK. Our health systems are somewhat similar, and that our vaccination rates were similar in the beginning part of the vaccination series. So looking at the UK, the one bright spot we see out of the UK is that their hospitalizations have not been surging. And so maybe that's a bright spot for us, but really it's too early for us to tell.
So really paying attention to that, on an ongoing basis. Dr. Jarvis, I have one other question for you, and this is going down into boosters. So I'm curious about planned U.S. expansion of boosters to those under 65 without underlying issues, as is underway in other countries. So for instance, UK is at 50 plus. Do we know when this will be discussed in the US, or is it based on whether we have available product to use?
So I'll say it is not based on available product. In fact, the United States has the single largest supply of vaccination of all three of the currently authorized vaccines here in the United States. It's one of the reasons why Novavax did not market their vaccine here in the US, because there was no need for it, even though we talked about Novavax very early on as being one of the bright spots coming down the pike for us. So it's not a matter of that. It is really a matter of reviewing the data and ensuring that we, one, get as many people with their primary series for the vaccine rather than boosters. And to date, particularly with the Pfizer and the Moderna vaccine, we know that people who were vaccinated even as long ago as 8 months still have significant protection against hospitalization, severe disease, and death. And those were the endpoints that we initially were asking for when we were talking about vaccines. So at this time, it's really following the data before we start talking about lowering that requirement, other than those groups that right now are being recommended for booster shots.
Excellent. Thanks, Dr. Jarvis. The next series of questions is for Dr. Hammond. So, Sue Ann, is the treatment for long haulers driven by the symptoms, or are all patients treated the same? And a connected question is there the equivalent of a magic pill for long haulers?
Yeah, at this time, there's no magic pill. We don't have an antiviral, so to speak, that will treat all of the symptoms. And patients are treated individually. So the treatment is very much focused on what symptoms the patient is having.
Okay, so it's very symptom oriented. Okay, thanks for that. I have two other questions from our audience. that overlap. So the first is, are you finding that a particular demographic is more likely to suffer from PASC? Also, do we know if there are any long-lasting effects from COVID for some patients who tested positive but were asymptomatic? And tying into that asymptomatic part of it, do we see individuals with long-term COVID who were initially not symptomatic? So a couple of things, demographics, as well as talk about asymptomatic leading to long COVID.
Sure. So I'll start with the asymptomatic. We do have reports of patients who tested positive for COVID and did not have any presenting symptoms initially, who 4 weeks later did develop a symptom. And there's a question of the link to, is it a brand new symptom unrelated, or is it related to their positive test? So yes, an asymptomatic person could have past or post-COVID symptoms 4 weeks later. As far as the demographic, there is not a clear pattern for demographics so far, no pattern for age or gender. The only trend that we've seen so far is that past or post-acute sequelae of COVID seems to be more prevalent in patients who had the mild to moderate range. So not the ICU patients. So patients who were in ICU, had a severe infection and were hospitalized, seem to be less likely to have the long-term post-acute symptoms at this time. Early data, but that's a trend that we're seeing now.
Yeah, so Sue-Ann, would it be safe to say that long COVID, whether it's for a couple of months after somebody recovered from the acute, or the chronic where it could go on greater than 6 months and no end in sight at this point, that this is a very important part of the disease process that perhaps our society is not paying enough attention to at this point?
I think so. I think, certainly we really need to work on educating because there's certainly a cohort of people that maybe are vaccine hesitant or reluctant because they think they're not at risk, they don't have a respiratory disease, or they're not concerned necessarily about a severe infection. But what we're seeing now with the post-acute sequelae is that those are the people who are having the peculiar longer symptoms. So they're having changes in their taste and their smell. They're having difficulty with word finding or organization. Brain fog is very common. An overall fatigue, a deconditioning, a feeling of being short of breath more than they ever have before for no reason. And so I think the more and more we can educate and share about these, this 10%, and all of this is very unknown and new, the more it can help to educate those that are maybe still considering getting the vaccine.
Great, thanks. I'll make a comment myself. I referred to in the opening statement the October 13th JAMA article, which was what's called a meta-analysis. They look at all the studies and then they combine them and try to draw some conclusions off of it. And one of the conclusions that's very concerning is that they're giving a heads up that we need to tool our healthcare delivery system to accommodate so many people who will have long COVID symptoms to deal with. So I think that's a large warning for all of us in healthcare, that there's going to be a lot of people that are suffering from this long term. And so we really appreciate the work that Dr. Hammond and her team are doing in the Mercy area to be able to get a long COVID clinic up and running and modifying as we learn more and more as we go along. So I'm going to switch gears to Angela Felicia. Angela, how can you tell when a normally strong person is having problems from the ongoing stress?
Sure. Yeah, so that will vary from person to person, but the hallmark feature will be any change from what is normal for them, right? So if you've got a person who's typically happy-go-lucky and they're suddenly irritable, cranky, frustrated, hard to get along with, that could in fact be a sign that they're struggling. Any appetite change, sleep change. Many folks eat more, but there are some folks who eat less. So really looking for any of those changes from normal could be that sign that someone's really struggling.
Mm-hmm. That's helpful. I have actually two questions for you, Angela. Is the stress on a person different for the first surge of COVID-19 and the very disappointing Delta surge that surprised us over the summer? So I guess that's the initial COVID-19 and all the stress that went with that. Then we had, like you said in your talk, around June or July, we kind of felt like this may be winding down, but then the big Delta surge occurred. And does the disappointment of that letdown make things worse? So trying to understand that a bit more.
Yeah, absolutely, right? That's been the hallmark of COVID, that just when we think it's going to be over, it's not. So this chronic nature of being under this perpetual need for hypervigilance. Gosh, do I have my mask to go into the grocery? Is it over yet? That unknown, all of those factors just make this crisis event that much worse. So yes, the short answer to your question is yes, it actually is a bit worse for folks the longer this goes on. And then when it looks like things are better, but not quite, right? That's continually stressful. We never get to that recovery phase where we can just let our brains rest again and get back to normal. We're just constantly in that fight or flight, which is pretty exhausting for the brain and the body, frankly.
So we need to recognize, I guess, that some people can really deal with, acute issues reasonably well. The end is in sight. There's light at the end of the tunnel, and we can get through this. Versus the chronicity where it comes right back at us before we fully recover from it, and then it's not clear that there's an end in sight, and there's maybe not light at the end of the tunnel right at the moment. Is that a good interpretation of it?
That's a perfect interpretation, because that's just overall exhausting. And when your resources are already depleted and you don't get that sense of, gosh, when do I get to restore myself? When can I shore up my resources again? That can really take a toll on people.
Yeah, thank you. The next question is for Dr. Jarvis. Colin Powell died from COVID-19 and he had the vaccine. Why did this happen, and how much protection do the vaccines actually offer?
Yeah, so it's an excellent question, Ed. So first and foremost, no vaccine is 100% in protecting against any particular virus. I will say that the three vaccines that are authorized in the United States actually exceed almost any capability we've seen with any other prior vaccine that we've utilized. So that's good news for us. But the case with Colin Powell, we have to remember that he was 84 years old. He actually had cancer and was actually undergoing treatment for his cancer. So he was at an extremely high risk that his immune system would not be providing as a robust a response to the vaccine as someone who's in their 30s and relatively healthy. And so that's the thing to kind of remember, is that everybody's a little bit different. What this should be is a warning to us all that in order to protect people like Colin Powell, who are more vulnerable, more people around them have to be vaccinated. So again, the less likely chance that they would be infected, and if they are infected, to spread the disease to somebody else who may have a weakened immune system. So it's just another call to arms. That this doesn't say that vaccines aren't working. What it says is we need more people to get the vaccines so that as a global community, we get a more effective response.
Great, thanks. I'll make a couple of comments about this as well. I was reading that Colin Powell, in fact, like you said, had cancer, one called multiple myeloma, which actually causes an effect at the bone marrow level for the cells that actually man the immune system. So he was very immunocompromised. He was also scheduled to get a booster shot, prior to passing away from COVID-19. And I think the real takeaway here is to understand that there are breakthrough infections. The breakthrough infections are more likely to happen when not enough people are vaccinated in the first place and there's community spread of the virus. So once again, reinforcing the need for everyone to get vaccinated. And that there is limitations to that protection that we see, particularly in the most vulnerable people who are immunocompromised, where they can't mount the necessary response, developing the antibodies to protect against it as effectively as someone who is not dealing with the immunocompromised situation. So a couple of messages buried in there.
Yeah, and Ed, I'd just point out that the CDC just came out with a recent report that said that people who have not been vaccinated are 6 times more likely to test positive for COVID-19 than those who are vaccinated, and 11 times more likely to die from that illness. And so, again, reinforcing the fact that those who are vaccinated get much more protection than those who are not.
Perfect, thank you. So, Sue-Ann, I see there's a question here for you, actually 2 that we'll work on. The first one, I think you may have responded to in writing, but if you would share it. So the question for you, Dr. Hammond, is do patients with long COVID have persistently elevated inflammatory markers? I suspect that's a clinician asking that kind of question. So if you may.
Sure. Interestingly, I haven't seen anything out of the US yet. There is a study out of Italy that was recently published showing that 73% of PASC patients, so post-acute sequelae patients, 73% did have elevated inflammatory markers. So that's new, but that's limited to 1 study. So I think it's a little too early to make any conclusions from that. And I know the next question about, a relationship with the fact that we do treat our hospitalized patients with steroids and anti-inflammatories. Certainly, it's a plausible theory, and one I'm sure we'll see more data coming out of soon. Just a moment to add, while Mercy has its clinic going and many other of the member orgs at Northern Light are also setting up similar clinics, locally, we've collaborated with Maine Health in Central Maine and Maine General in Augusta, so that we're sharing our information. It's all HIPAA compliant. We're not sharing patient names, but we're sharing the theories, and we're sharing the themes, the patterns of what we're seeing. And then we've been lucky enough at Northern Light to be invited to the table at Mass General and Brigham. So every quarter, I'm able to sit on case studies where they talk about things like this, and they're looking at the trends in the studies worldwide to share that information. So as you said earlier, education is just going to be huge because, as I said in my presentation, we don't know what we don't know, but we can learn. And so as we move forward and see things like anti-inflammatory or steroid use, reduces that early on, those are the things we hope to be able to share with our patients by being able to reach out to them and say, you presented to our clinic and you had this particular symptom, and now we know more about it. And these are some of the treatment options that we are hoping to share moving forward.
Yeah, during your presentation, you shared with some of the possible causes of long COVID, and some of them seem to be related to ongoing infectious process, and some perhaps not. Maybe the body's response to the initial insult from an infectious disease. And could that potentially explain the difference between those with PASC who do have elevated inflammatory markers versus not?
Yeah, I think, it's so hard right now because we don't have all the information, right? So if we were able to take every person who tested positive and look at their symptoms at presentation, their symptoms at the 4-week mark, 6-week mark, and we need to start doing that. We need to start building that database that says, what do these patients who did well have in common? And what do the patients who didn't do well have in common? So those are the things that are ongoing and are going to be important in the months ahead to figure this out.
Great, thanks. I have one more question for you, Dr. Hammond. For someone that had COVID in March of 21 and continues to have brain fog and was exposed to other mental trauma leading up to getting COVID with processing of PPP loans, I'm not sure I understand what that is, but maybe you do. How long should the brain fog continue to last? So if you need to, you can borrow Dr. Jarvis's crystal ball.
Yeah, and I think it's a crystal ball question. I think the PPE loans, I think you're referring to somebody who maybe was a business owner and had a lot of financial challenges in getting those loans. And so there's that mental stress that Angela, talks about, the mental stress and anxiety that went along with the pandemic. And then this particular person is referencing somebody who then got an infection and now has brain fog. Right now, what we know from our partners at Mass General is that cognitive speech and language therapy has been quite useful for people with brain fog. Cognitive speech and language therapy is a little confusing because we think about a speech therapist as somebody who helps a little kid learn to talk, or a speech therapist will work with somebody who's had a stroke and is learning how to speak or swallow. But a cognitive speech therapist actually works on the whole connection between the brain and the mouth and our communication skills, whether it's by writing or speaking. And so a cognitive speech therapist can help with strategies on how to overcome the brain fog, how to train yourself or retrain yourself to try to see improvements in that. So you're right. I don't know how long you can expect for that. We just don't have those answers. But I do know that there are therapists out there working to help patients who have those symptoms.
Mm. I have another question that's kind of a long arm distance relative to that question. Is there concern for dementia long-term related to COVID-19?
That's a tough one. I haven't seen it yet, and I think it's probably way too early for that. I think as we look at these patients down the road, 6 months or a year from now, patients who continue to have symptoms, I'm sure somebody is already studying that and thinking about that, but I have yet to see any correlation in the studies that I've reviewed.
Okay, so pay attention, right? Okay, thank you. Dr. Jarvis, I have a couple of questions for you. How have antibody tests, the quantitative, et cetera, advanced over the past year, and are these good tools to determine booster needs for those on the fence in terms of underlying issues? So I think there's two questions buried in there. One is about the antibody tests, and then how do you determine if somebody needs a booster?
Yeah, so the two good questions. So as far as the antibody tests themselves go, the first development was, of course, having one. We never had one before because we never had antibodies against this particular coronavirus. And so they've evolved in that way. They've become faster, so our turnaround time, and a little bit more specific, meaning that they specifically target the antibodies towards this specific coronavirus versus other coronaviruses that you may have been infected with before. So that's good news on a testing front. But on a clinical front, most of that has no relevance to us whatsoever. In fact, there's very limited relevant clinical information given to us by an antibody test. And there's a couple of reasons for that. One, we do not know what level of antibodies confers immunity for any particular individual. And it may very well be that for one person, a level of 1,000 per whatever it is that we're measuring is adequate, where somebody else needs tens of thousands for that to have the same level of adequate protection. We also know the immune system in the human body is very, very complex, and antibodies only play one part of that. And we're finding more and more that in coronavirus, it's probably some of the other aspects of our immune system that help ward off the infection as much as antibodies do. And so it makes it very, very difficult. So at this time, it's the reason why we are not using things like antibody levels to exempt somebody from a vaccine mandate or to recommend booster shots. And so there may be some rare clinical scenarios where it may play some kind of role, like in somebody who's known not to create a significant antibody response to other vaccinations. But really, when it comes to this one, we just don't know. And at this time, it's better to get vaccinated and get the booster if recommended than to wait for antibodies to be the end-all, be-all, because that's probably not going to ever be our answer.
Yeah, I kind of see it that way as well. I have another question for you, Dr. Jarvis. What do we know about the effectiveness of boosters, particularly Pfizer, on the Delta variant?
Yeah, so what we know is actually that the original series that people received is very effective against the Delta variant. Now, we know that the Delta variant is certainly more infectious from person to person, and so that has to be taken into account when we look at that. But thankfully, the spike protein that the currently authorized vaccines target is the same. That spike protein is the same in the Delta variant and including its subvariants. So that's very good news for us. And so when we talk about boosters, it's really just adding to the protection that we've had against the original strain, the Alpha strain, and now the Delta strain. Of course, the concern is, well, what about that next strain that we haven't even given a Greek letter to, and we just don't know? And so, be on the lookout for us needing to change. But it's really the reason why the vaccines were not tailored any differently when we talked about those boosters, like we talk about when we're talking about seasonal influenza, where we tailor it year to year, because we haven't had to do that. Right now, the 3 that are authorized still give very, very good protection against the Delta variant.
Thanks, Jim. Angela, a couple questions for you. Is it more useful for my children, their friends, and younger employees to see me as a source of strength and resilience, or another vulnerable human with similar concerns as theirs? Oh, that's kind of like a role modeling question.
Yeah, that's a fabulous question, actually.
I think I might have asked that question a time or two in the past, too. So.
I think we probably all have. Yeah, absolutely.
Yeah.
So the answer really is yes to both, right? So yeah, we actually want to show ourselves as human, vulnerable, real. And we want to give particularly kids, young people, folks that maybe look up to you. Gosh, we also want to give those folks some tools or suggestions. Gosh, this is how I've been dealing with the stress of COVID. This is how I've been dealing with the stress of remote work or school or whatever those major stressors are. This is what's worked for me. It might work for you. There's absolutely nothing wrong. And in fact, it's perfectly human to show that vulnerability and can be pretty helpful so that people don't feel as if they are alone.
Great, thanks. Another similar kind of question. How do I engage my staff to talk about stress reduction strategies? I think we need to agree we have problems. Am I overstepping as a small employer?
Yeah, that's a great question. So establishing as sort of a norm in your culture, boy, we're going to check in with each other and see how we're doing, can go a long way. And then have that conversation around, gosh, this is what I'm doing. I've been recently hearing folks saying, gosh, I'm going to try to end 60-minute meetings at 50 minutes or 55 minutes, and encouraging people to leave their computer, get up from the conference room, walk around, so that you are encouraging, again, that modeling word, by modeling some of those stress reduction strategies. And it is perfectly okay to ask people, how's it going? How are you doing? What can we do to help? That again shows that humanity. We're all sort of in this together. You're not alone.
So it sounds like the risk to take is to engage people as a small employer and really see how they're doing.
Yeah, absolutely. The risk of not doing that is probably greater, where you might lose good employees, which certainly, with this current job market, none of us can afford that. And then people are going to get increasingly burned out or increasingly stressed, maybe needing sick leave, that sort of thing. So yeah, really checking in and keeping that humanity is key.
Thank you. Dr. Hammond, a couple of questions for you, and this is probably a little bit more of a detailed type of question related to the demographics of who gets long haulers. So the first one is, does long haulers happen to healthy young people? And does long haulers happen just to people who were very sick in the hospital? So I think you touched on those, but maybe clarify that for us a bit.
Sure. Long haulers does happen to young, healthy people. It can happen to anybody, but it is less likely to happen to somebody who is very sick. So Patients who were sick in the intensive care unit, ventilators, and were hospitalized are less likely to have long haulers. Long haulers is more likely to occur in patients who have a mild to moderate illness, any age, any gender, but a mild to moderate illness is typically where we're seeing more of the long hauler syndrome. But it can happen to young and healthy, and it can happen to somebody who was asymptomatic when they tested positive.
Great, thanks. I see a comment in that chat room that I'll share. In our workplace, we have discussed the importance of self-care. And Angela, I know you and Yamaya have talked about that quite a few times for us. One being having a sober October, knowing nationally alcohol consumption is up. Please comment on that, Angela.
Yeah, that's a great point that the participant raised, right? Nationally, alcohol consumption is up. And unfortunately, there's also sort of a buzz about increased alcohol consumption sort of being the way to go, right? Lots of memes and GIFs and jokes. Increased alcohol consumption can lead to some serious health issues. So paying attention to alcohol use and really reducing it when possible. And in fact, what's recommended, the maximum recommended for women is 1 drink a day. So that's only 7 drinks a week. And maximum recommended for men is 2 drinks per day. So if you find that you're drinking more than that maximum recommendation, that's something to really be aware of and take note of, and potentially get some assistance with if needed, if you find that you're just not able to stop drinking.
I'll comment, Angela, 7 and 14 drinks per week sounds like to some very little, to others very much. So it's kind of a relative concept, how much to drink, huh?
Absolutely.
Yeah. Dr. Jarvis, you talked a lot about new cases, hospitalizations, not so much about ventilator use at the beginning of your presentation. So what is the situation in Maine with new cases, hospitalizations, and ventilator use? How bad is it from an insider's view?
Well, capacity issues are concerns that Maine has, all the time, regardless of the pandemic. The pandemic just highlighted it even more, as has several other recent events. So there is always a strain on the health system across the state of Maine. We have talked often during this forum that historically Maine has not had enough hospital beds, long-term care facilities, or skilled nursing beds to meet the demands of our community, particularly because we are a diverse community in that our summer months we swell to sometimes from a population of 1.3 million to 10 million because of tourists and visitors, and we're still seeing the after effects of some of that visitation right now. So that's just a normal part of things that we do. You add to that having, a large medical center like Eastern Maine Medical Center or Maine Medical Center, having an additional 20, 30, 50, 60, 70 patients that they typically would not have who require intense nursing care like COVID patients often do. That just taxes the system even more. And remember, we still have responsibilities to continue to take care of people who have been in car accidents, people who have heart attacks, women who are in labor who need a safe place to deliver their babies, children who need health care. Those are the things that we do day in and day out, while now having to deal with yet one more issue in an already strapped thing. So yes, it is quite dire out there. There are certainly some hospitals and some health systems that are strained more than others, but at any moment that could be any one of your local hospitals. And so again, it's a plea to help us help you by keeping yourself safe, well, keeping your family members safe and well, as well as your communities. Vaccination, masking, washing your hands, social distancing, staying home when you're ill. So thanks, Ed, for giving me that last word.
Yeah, absolutely. Well, that wraps it up for today. Our next session will be on November 4th. Dr. Jarvis, our physician leader for COVID-19 communications, Dr. Marnick, an immunologist from Hudson University with a passion for making complicated science understandable, and Yamaya St. Clair, a mental health workforce counselor, will join me for a roundtable discussion focused on your questions. We will give you a brief update on hot topics, then launch into the roundtable discussion. This format was used in early October, and so many great questions were raised by our audience that we decided to do a sequel. Send your questions, tighten your seatbelts, and let's see what we all will learn. One guarantee, it will be time well spent for all of us. We will send you the link for this session. We encourage you to share the invitation with your friends, colleagues, and others who might benefit from this information. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.